Welcome to the fourth and hopefully final installment of Cardiac Pharmacology, Coronary Artery Disease. In this segment, we're going to look at the medications used for treatment of coronary artery disease, angina, and myocardial infarction. Beyond that, hopefully we'll get to talk about medications for coagulation and coagulation disorders. So without further ado, on with it. The pharmacologic interventions for angina include medications like nitrates, beta blockers, calcium channel blockers, aspirin, and oxygen, with the overarching goal of all these medications to reduce oxygen demand and increase oxygen supply. You know that your physiology, your pathophysiology of angina is that ineffective tissue perfusion, where the narrowing of the artery decreases the oxygen supply, and the myocardial workload, if it increases, will increase the demand for oxygen. So between these medications, we hope to do both of those things. Things you can do to reduce the oxygen demand are things like reducing the heart rate, so something that's a negative chronotrope, reducing preload, reducing contractility, and lowering blood pressure, which is reducing afterload. To increase the oxygen supply, you either can vasodilate or provide supplemental oxygen and therefore increase the amount of oxygen that's in the blood supply. Nitrates are your go-to medication when it comes to treating chest pain or anginal pain. Your prototype drug is nitroglycerin, with a mechanism of action of relaxing arterial and venous smooth muscle to dilate coronary arteries and all arteries and veins, thereby lowering myocardial oxygen demand by reducing preload and providing increased supply. The adverse effects of nitro are hypotension, which is a big one, and headache. Dizziness may occur related to hypotension. You also may have flushing of face, rash, and nausea. There's short-acting nitrates, for example, nitroglycerin or nitrostat, which is given sublingually. And there's specific rules for dosing with that. Nitropaste is a transdermal form of nitrate that is also a shorter acting. And then there's a longer acting, which is more for decreasing the severity and frequency of anginal episodes. So isosorbide dinitrate and isosorbide mononitrate are the PO drugs that can be used for patients that have chronic coronary artery disease and need to have longer-term anginal control. Remember when placing Nitropaste to put your gloves on. Okay, you haven't really lived until you've gotten a nitro headache because you got some paste on your fingers. Careful measurement isn't as important as it used to be because most of the time now it comes in packets that are considered 1 inch. If you're giving half of an inch, then you have to be sure to measure carefully on the applicator. Generally, place your nitro patch on the chest, upper thighs, arms, and abdomen. Do not put on bone, and please don't put it any place where you may need to defibrillate somebody. Because in an emergency situation, if you try to defibrillate over nitropaste, you're going to cause a burn, it could arc, it could explode. There's all kinds of bad things that could happen. So, knowing that, don't put it in an area over the left side of the chest where you may be defibrillating. Very important to tape it on, date it, and time it. Sometimes you'll have patients that are walking to the bathroom in the morning and you have multiple nitro patches hanging off with half a tape. So you know that whoever put on the previous nitro patch perhaps did not remove the one before it. So when you're giving transdermal nitro, make sure to remove the one before it, wipe it off, place it on a different areas to reduce skin irritation, and make sure that you date and time it so people know what dose is placed there. When you're giving nitrates, you always want to think about obtaining blood pressures before and during administration. And IV nitrates have the shortest onset of action and therefore have the greatest risk for severe hypotension. They can be controlled a little bit better because they have their shortest half-life, but please be sure to closely monitor patients on IV nitrates. Old protocol was Q1 hour blood pressures. They may have changed, but you definitely want to make sure that you're monitoring patients on nitrates very closely. You want to educate the client that alcohol is contraindicated with nitrates. Okay? Alcohol is kind of contraindicated with most medications. If hypotension occurs, withhold nitrates. So this is one of those things that it depends if you're giving it in an emergent situation or if you're giving it in a more chronic situation. If a patient is having active chest pain with potential EKG changes, you're probably not going to want to cut down on the nitrates because you're going to want to try and get as much oxygen to the heart muscle as possible. But you really need to watch, and if a patient's blood pressure is dipping, you need to make sure that they're in the bed, make sure that they've got an IV and possibly IV fluids flowing. Okay, what about those meds for erectile dysfunction? What's going to happen if they're taking sildenafil and also taking a nitrate? Okay, you know what's going to happen. Right? Keep that in mind. That's something that, especially if you're working in an emergent care situation, you'll come up against, and it's important to be frank with patients and ask them to be honest with you. Okay, with nitrostatin sublingual, the patient education storage. It needs to be kept in the original bottle. Okay, it gets degraded with light, so you need to make sure they keep it in the original bottle. They need to refill the prescription. They can't just keep the same bottle of nitro for years and years and years. Okay, it's important for the patients to know how to administer and when to call 911, and also that they should sit down if they're giving themselves sublingual nitro because of the risk for orthostatic hypotension. Okay, you call 911 when chest pain is relieved by one sublingual in 5 minutes, or unrelieved by one sublingual after 5 minutes. Hey, beta blockers. Okay, your prototype, atenolol. Really, you could be giving atenolol, low pressor, lots of different ones. In patients with angina, the mechanism of action and the purpose of beta blockers is to reduce cardiac workload, and by doing that by decreasing heart rate and decreasing contractility. So this is something that's more of a prophylaxis. Patients who have chronic angina will take beta blockers as a longer-term treatment to reduce some of the demand that's going on. And we've already reviewed the adverse effects of beta blockers. Just a couple of reminders. Assess apical heart rate and blood pressure and continue to monitor. Assess and monitor lung sounds and monitor your serum glucose levels if the patient has diabetes because you can mask the effects of hypoglycemia. No stopping beta blockers abruptly due to the risk of rebound hypertension. Calcium channel blockers' role in treating coronary artery disease is vasodilation. Okay, it can reduce cardiac workload by relaxing smooth muscle and dilate the coronary arteries. Okay, so you might see this being used. Think about your side effects as it relates to that. With calcium channel blockers, you want to assess vital signs. If the client's hypertensive, hold the medication. Obtain the blood pressure in lying, sitting, and standing positions. Okay, watch for daily weights and assess bowel functions because there can be a risk of diarrhea versus constipation with calcium channel blockers. Also very important, just as an addition, anytime you have meds that are going to adjust heart rate, blood pressure, contractility, make sure that there are hold parameters written before you give the medication. Okay, lots of physicians will order a beta blocker or a calcium channel blocker and not write a hold parameter. If you have a question, hold it until you can clarify with the physician. Visual, just showing the mechanism of actions of drugs used to treat angina. Okay, and it kind of shows the different areas where it works and how it works. With acute MI, the immediate goals are to relieve chest pain by restoring blood flow, and that's important. You want to correct the pathophysiology. Pathophysiology is hypoxic heart muscle, so we want to get the blood flow back to it. Secondarily, we want to reduce the extent of myocardial damage, and that's kind of by acting fast. The quicker you can get the blood flow restored, the less damage you're going to have. Reduce the demand of the heart, reduce the amount of mortality afterwards, maintain cardiovascular stability, decrease cardiac workload, and ultimately prevent complications of an acute MI. It is as it says, it's an acute event, it's an emergency event. So, pharmacology, okay, these are not things that we haven't talked about before. We've talked about the acronym MONA. I like to say NOAM because my top two priorities are nitrates and oxygen. I want to get as much oxygen into the tissues as possible. Aspirin, the antiplatelet, because if you have sluggish blood around that area of blockage, it could cause a clot and obstruct it completely. Analgesia. Morphine has been the name to go to, and morphine has the double effect of vasodilation as well as analgesia, and it can also relax the patient so that the sympathetic nervous system doesn't go into effect and start to increase myocardial oxygen demand. It's rare, but you can give thrombolytic agents, okay, or antidysrhythmics. More often than not, if someone comes in with an MI, they're going to take them into the cardiac cath lab for angiography and revascularization procedures. Okay, and this talks a little bit more about NOAM, or MONA, as I like to say. Okay, now we're going to start getting into the platelets. And I have a feeling that the last part is going to be part 5. But the antiplatelet aggregates. Okay, and this is important. A lot of times when you see the meds, there are meds that are antiplatelets and there are meds that are anticoagulants. They're not the same. Aspirin, clopidogrel, and ticlopidine are all antiplatelet aggregates. So they keep clots from happening, but they're not anticoagulants. They reduce the stickiness of the platelets, as you were. Thrombolytics are the clot busters, or fibrinolytics. So they're going to lyse the clot that's in that coronary artery. But the problem is it's going to lyse every single clot you have. So if a patient has a venipuncture, they're going to be bleeding out of the venipuncture as well. So I personally have not seen thrombolytics used as much as some of the interventional procedures like stents and CABGs. So for thrombolytics, and when you talk about strokes, you probably talked a little bit more about the rules for thrombolytics. You have to look at benefit versus risk. If the duration of chest pain is less than 6 hours, it's been shown to have some benefit. Okay, there's a lot of different things that are going to be involved, and you have to make sure that there's no changes in neurologic status or GI bleeding with the thrombolytics. Streptokinase is an example of a thrombolytic. TPA is an example. I'm not going to spend a whole lot of time on these, but just so you can kind of see that these are different things that can be used to lyse clots. Other drugs that are used for myocardial infarction, the beta blockers are going to reduce the oxygen demand by decreasing the heart rate, slowing impulse conduction. ACE inhibitors. Okay, ACE inhibitors are used mostly for hypertension, but research has shown that placing a patient on an ACE inhibitor after or during an MI will increase the survival and will limit remodeling of heart muscle. And remodeling of heart muscle is that if you lose part of a heart muscle, the shape of your heart's going to change because that's no longer going to be a functioning and viable contractile part of your muscle. Calcium channel blockers, dilation, decreased workload. Nursing process, very important. Monitoring client's condition, education, vital signs, vital signs, vital signs. Weights are going to be important over a period of time because a big risk of MI is cardiogenic shock and or longer-term heart failure, in which case you have to deal with fluid volume excess. So weights are important. Okay? The most common or the priority nursing diagnosis is ineffective tissue perfusion, but here's a list of some other things that can be used. Implementation over the long period, encouraging compliance, making sure that the client gets their nitro renewed every 6 months, lifestyle changes, and emergent care and what the patient needs to know. This concludes part 4 of Cardiac Pharm. Stay tuned for a brief part 5 where we discuss coagulation disorders. Thank you.